Once you've done this profile, then it gives you an idea of what you're dealing with, whether you are dealing with an acute infection, whether you're dealing with a chronic inactive infection or chronic active infection. So the third thing you now do is, so now let's say results come, and then you convince yourself that, all right, okay, so this is an acute infection or a chronic active infection. It means that the virus is actually actively replicating, so you need to manage that. What we need to do next is, how many viruses do we have in the blood at the moment? Because without the knowledge of your viral load, you wouldn't be able to follow up on your management. So we do what we call viral load, and we are doing this because we want to be checking as we keep managing, okay? Because you need a baseline to start your management with, and you need to observe progress of your management. And how do we do that? We do that by basically observing the number of viruses you had. You compare the number of viruses you have 3 months in 3 months time to the number of viruses you had in the past. You do all that, and then okay, I'm managing the case well. I'm having challenges in managing the case. Maybe I should change the medication. So after your first thing you do, which is looking out for surface antigen as positive, and you request for your viral profile, the third thing you do is a viral load. And once you do your viral load, you start managing your patient, okay? So slide 13 shows how to manage your patients. We usually put them on oral tenofovir. And then, as I said, you check your viral load with time to see how your progress is going, okay? If you've got cash, there's a medication called pegylated alpha-2 interferon, and we give it subcut, and it's quite expensive. Usually know that once a patient gets Hep B and then you manage, 99.9% of the time, once you move the patients from an acute viral replicative state, the surface antigen, which is the marker of a past infection, doesn't disappear, or which is a marker of an infection, doesn't disappear, okay? So if you've been exposed, should I say a marker of exposure, doesn't disappear. So if you've been exposed to Hep B in the past, and even now you don't have active viruses replicating, the Hep B surface antigen will always stay positive, 99.9% of the time. It's in rare cases that it will just disappear after you manage. It would always be there. So when you come and then we want to check how your management is going, we don't go back to check the surface antigen, because when you check, it doesn't go away. It will still be positive. What we look out for is a profile to see if you've converted back to an active viral state or not. Okay, so that's what we do. So we put them on this medication, and then it goes on. Of course, we all know about Hep B vaccine, that you can give 3 doses at the instant, 1 month after, and then 6 months after. Okay. Managing Hep C is a little bit, the process is quite simpler as compared to Hep B. In Hep C, we only come forward and we look out for the presence of the Hep C virus. So we'll test. So once Hep C virus is present, then we just move on to check what we call the genotype of the virus you have, because the genotype of the virus you have would determine how long we should put you on medication for. And when you check the slides, you see that there are 6 genetic variations, okay? So each variation has a particular duration of management, but we'll leave that one to the specialist, and then the gastroenterologist, and then hepatobiliary specialist. Your own is to diagnose. Once HCV is positive, diagnose. Your request for genetic variations, which your PCR will tell you, and then thirdly, you do a viral load just to tell us the number of viruses. Then you can refer for the specialist to manage. Okay. So once they go and see the specialist, they will usually start them on the pegylated alpha-2 interferons if they've got the cash, or they can do the oral ribavirin. Sometimes you can combine the two, just like the way Hep B, we can combine tenofovir and pegylated alpha-2 interferons. In this case, you can also combine ribavirin and pegylated alpha-2 interferons. And whilst you treat, you keep monitoring the viral load by PCR so that we can tell that indeed your management is working, your management is effective or not. Okay. So that's Hep B and Hep C for you. Hep D, remember I said that on its own, I mean, basically you won't have any issues, but once it's combined with Hep B, the issues start. Please just a minute.
All right.
Yes, sorry about that. I'm back. So usually for Hep B, once you have it in combination with Hep B, then we manage it as such. But just know that once you have the two, then your chances of going into chronicity is quite high. And once you go into chronicity, we've all gone through the complications, the fact that it can lead to cirrhosis, and then eventually you can develop hepatocellular carcinoma. Okay. So before I move on to complications, I'll take questions now, and then we move on to the next phase for today's lecture. So any questions so far?
Okay, so I have a question.
Yes, Jepta.
Okay. You said the surface antigen, once the person you are doing the treatment, you don't need to check for the surface antigen again because it will still be there. So
yeah,
my question is that even after treatment,
yeah,
the person will still be having the antigen for the rest of his life or something.
yeah. So yes, so that's the thing, and that's what usually makes people sad, because once they still have the S antigen, they feel they've got the virus in there. But the most important thing is whether you are in an active replicative state or not. I said 99.9% because it doesn't usually happen, especially in our environment here. It doesn't happen. Maybe outside, when your insurance will be able to cover for pegylated interferons, you'll be so fortunate. But for me, I'm yet to see a patient who has successfully gone through treatment and has the surface antigen disappearing. I mean, I've heard of one of my bosses, who is an infectious disease specialist, told me about one case that by some divine intervention, when they managed afterwards, they checked and it was gone. There was no surface antigen. So that's why I said 99.9. It doesn't happen, especially in our environment. But the presence of it doesn't mean that the patient still needs to undergo medication or treatment. Okay. The presence of it only tells you that, okay, do further investigations and let's see if this patient is in an active replicative state or it's just a chronic inactive infection. So the presence of the surface antigen doesn't really matter after your profile comes back and tells you that this is a chronic inactive infection. Okay. Or if it tells you it's a chronic active infection, then you manage and then you check your viral load. Because once surface antigen is positive, if it's a chronic inactive infection, you check for viral load, you won't find anything. Okay. It will be basically undetectable. So we don't worry about that.
Okay, thank you very much, sir. And so if someone comes to you and the person has gotten the virus before, you don't start with the surface antigen, just move on straight to the HB profile. the viral
Yes. So how would you know? Unless the patient tells you that I have gotten it before.
profile?
But
Yeah,
usually
so
most
usually
people
write in
don't
the
know.
history of- Okay.
Yes. Usually most people don't know. So that one, you as a clinician, maybe your patient comes to you right upper quadrant pain, fever, something. And you as a clinician, you start thinking along that line that before you go and do a scan, maybe the scan out. Because if it's acute hepatitis, you might not see much on the scan. Okay, maybe the gallbladder is inflamed. Maybe you would see it on the scan. That can also give you right upper quadrant pain because the gallbladder is there. But whilst you are thinking about hepatitis, you need to rule out the causes of hepatitis. And our previous lectures, we talked about it. And we said hepatitis, which will usually come with fever, you are thinking along the lines of an infection. So then you have to explore the infectious causes of hepatitis. And Hep B and Hep C in our environment is the commonest. So that is what is going to prompt you to test for Hep B surface antigen. Okay. Otherwise, I mean, the patient can't tell you. But if the patient says, "Oh, the doctor has told me I have Hep B in the past," there's no need going back to do a surface antigen for the patient. Just go straight and do a profile for the patient.
Okay, so thank you very much.
You're welcome. Now
Okay,
take
sir.
2 more questions. Yeah, Ivan.
Yes, sir. Please, my question is on the markers, the IgM, the IgM and the IgG. Please, can you elaborate on that part, the IgG and the IgM? Because you talk about chronic active and chronic inactive.
Chronic inactive. All right.
Yeah.
Okay. So just make it simple for yourself. Whenever you are asked, whenever you are in your consulting room and you request for an investigation and it comes and you have IgG and IgM, know this: IgM is a marker of acute infection and IgG is a marker of a chronic infection. Okay. So that's what you should know. That's what you should know. So if the infection is in the acute state, IgM will be positive. IgG would usually be negative. If the infection goes past 6 months, then your body will start making IgG. So IgG will be positive. I mean, what this means is that usually when you have an infection and your body starts making antibodies, the first antibodies that are called upon are the IgMs. And then later on, the other antibodies that your body would make, like a memory antibody to prevent future infections, is your IgG. Okay.
Okay.
So basically that's it. Yeah.
So you always have to request, because when you look at the markers, on the markers,
Yeah.
you don't have the IgG and the IgM on the markers.
Okay. Okay.
Yes.
So
how do you request?
Ideally it's supposed to be the ones you request for a viral profile and they are coming back to tell you Hep B core antibody is positive. They have to specify which of the core antibodies is positive. It's not enough for them to just come and tell you Hep B core antibodies positive, but there are 2 types of antibodies. So if they tell you Hep B core antibody is negative, then it means that both IgG and IgM is negative. And that's the reason why usually they won't specify IgG, IgM. But once it's positive, they will specify whether it's IgG, IgM, or whether you have both IgG and IgM positive. Do you get me?
Yes, sir.
Yes. Great. So it's the same technique for doing a typhoid IgG, IgM. Most of the time people do without, but the gold standard for diagnosing is not without. But if you don't have culture and you decide to do without, you need to support it with typhoid antibodies, IgG, IgM. Okay. So then if your withdrawal is high, then you go and look at your IgG, IgM. Because most people who come to you with typhoid have taken Cipro. They'll tell you, oh, Dr. Simi was typhoid. It's been years, they'll tell you. So now what shows that what you are seeing there is not an old infection? The only way you know is either you do a culture or you do an IgG, IgM, and the IgG will tell you that, oh, this is a previous infection. The patient has even made IgG antibodies towards this. So don't bother yourself putting your patient on Cipro. Or you check an IgM is there and it'll tell you, oh, there's actually a new infection because the patient is even making antibodies, IgM antibodies. So manage it as such. Okay, so once we get there, you see, but IgM, acute infection, IgG, a marker of chronic infection. Don't forget. Okay, now I'll take the last question.
Hello, sir.
Yes, please.
Sir, I have a question.
Yes,
so
let's take it.
It has to do with chronic hepatitis B. So I want to
Yes.
know if your patient is having a chronic hepatitis B. As a clinician, must your concern be about how the liver must you be concerned about the scarring of the liver, or there won't be a case where the chronic hepatitis B will lead to scarring of the liver?
Okay. Yeah, so that's an excellent question. So you remember in class we said something about disease progression, and disease progression, what we meant was that once you have hepatitis, it can run various courses. So you can run an acute course where the acute course, you can have resolution of the disease, okay? Or this disease, acute, won't just resolve, but it will lead to fulminant hepatitis, whereby you develop hepatic encephalopathy in less than 2 weeks' time. Okay, you can have that. Or you can even have the patient dying from that. Or the last course it can run is from the acute state, you move to a chronic state. When it moves to a chronic state means that the infection, you've had infection, it's past 6 months. Even though the acute state has resolved, there's still a little bit of inflammation going on, which has moved past 6 months. So then we say you have chronic hepatitis. Yes, you should be concerned about possible scar formation, but not every patient would go through the progressive course. Not everybody with chronic hepatitis would end up having cirrhosis. Not everybody with chronic hepatitis will end up having hepatocellular carcinoma. Otherwise, you have so many cases of cirrhosis and hepatocellular carcinoma. But if you have a chronic hepatitis and we don't remove the infecting agent or the inflicting or afflicting agent from there, then your risk of progressing to complications of chronic hepatitis or further on cirrhosis and a possible HCC would increase, okay? Because already there's some sort of inflammation. If we try to halt the inflammation or slow the progression of the inflammation by good lifestyle modifications, you stay away from alcohol, you make sure sexual protection is good, you don't get another Hep B infection, you know, all that, then we know that you're on the right course. You don't take herbal medication, you're not taking overdose or too much of paracetamol, you're not taking unprescribed over-the-counter medication, then we know that you're on the right path. So even though you might have Hep B surface antigen positive and you've gone beyond 6 months, you have a chronic hepatitis, we know that possibly you stand a higher chance of not developing what's the scarring of the liver or the cirrhosis, okay? But if you are doing all the negatives, then yes, you would develop cirrhosis eventually and possibly hepatocellular carcinoma, or sometimes you might not even see the cirrhosis coming, you develop HCC straight away. Okay, and that's how the disease is. So we always try to keep an eye on scarring of the liver, and that is why it is essential to do follow-ups for your patients who have Hep B surface antigen. All my patients with Hep B surface antigen positive, whether as an active infection or a chronic inactive infection, I see them frequently. Those who have chronic inactive infection, every 6 months, I will need you to repeat your profile for me because I want to see if something has changed. I'll need you to do an LFT for me. I'll need you to do a lipid profile for me because remember we said non-alcoholic fatty liver disease. You can also have fatty liver making a disease or causing hepatitis, basically excessive fat causing hepatitis. So you need to do all those things for me so that I'll be convinced that you're on the right path. Every 6 months, I'm doing your profile, I'm checking your LFTs to see you're on the right path. And possibly I'm doing an ultrasound scan for you. All this because I'm looking out for a possible scarring or hepatocellular carcinoma. Okay. Are you okay with that, please?
Yeah, thank you very much, sir.
You're welcome. So basically that will move us to chronic liver disease.
No,
Yes, Richard. Okay, Richard, I'll take your question and then we move on.
Yeah, no.
Yes.
Please, though, you know the rapid diagnosis determine the surface antigen.
Yes.
Oh, okay.
You
Is
said
it
what?
possible that somebody, the rapid diagnosis test we use for Hep B,
Yes.
determine the surface antigen?
Yes.
For
Yes. Yes.
antigen. So is it possible the person can test it and be on LIN52, then later on tested negative?
Okay. Well, I'm yet to see some. I'm yet to see LIN52 convert any patients from surface antigen positive to negative. I'm saying this because, I mean, in the past, I used to give a lot of LIN52 when your surface antigen is positive, and then I check your profile, everything is fine. I'll say, okay, let me, as part of protecting your liver, let me put you on LIN52. Sometimes, okay, it's more of a supplement. But all my patients, as I said, I do reviews for them and I check every 6 months. I'm yet to see anybody convert from surface antigen positive to negative on LIN52. Yeah, unless by some divine intervention, maybe the person prays very hard and God surprises the person, but I'm yet to see that happen. So sometimes it's actually not necessary to give you a LIN52. It's fine. It's okay if your patient comes with right upper quadrant pain, Hep B surface antigen is positive. However, the patient has a chronic inactive infection, right? So you give something for pain. In this case, you don't want to give paracetamol because it will make your hepatitis worse. So maybe you give some tramadol or something, because end states too can cause liver problems sometimes. So you don't want to give a tramadol, which would sort out the pain. Yeah, it's okay to add a liver supplement like Livomin or LIN52. But if a patient walks to your consulting room, surface antigen is positive, however, E antigen is negative, patient is not actively replicating, no pain whatsoever in the liver area, I don't think it's important to give LIN52 or any liver supplements. You just counsel your patient on lifestyle modifications and you're good to go.
Okay, thank you very much.
You're welcome. So we said that usually once you progress past 6 months, then you are going to develop chronic liver disease, right? Once it goes beyond 6 months. And chronic liver disease is basically a broad term which encompasses chronic hepatitis, cirrhosis, hepatocellular carcinoma. So if you say a patient has chronic liver disease, you need to specify what kind of chronic liver disease does the patient have. Are you trying to tell me that this patient has a chronic liver disease, just some chronic hepatitis, or the patient has actually gone past chronic hepatitis and now has cirrhosis or a possible hepatocellular carcinoma? Okay, so chronic liver disease is just a broad term. And then under that, you have chronic hepatitis, which is just an inflammation of the liver. In this case, you don't have any scarring, it's just an inflammation. The liver might be a little bit bigger than usual, what we call hepatomegaly. Or you have cirrhosis where there's an inflammation, and inflammation has led to what we call a fibrosis. And the fibrosis in itself has caused the liver to shrink in size, and it's caused the liver to become hard and nodular, okay? Or you've gone past that and now you are dealing with a cancer. When you have a cirrhosis, yeah, eventually you end up losing the patient, but cirrhosis won't spread to another place. But once you have HCC or a liver cancer, then there's a possible metastasis where you can have the cancer moving from the liver through the blood or portal system going to other places, right? So HCC is more dangerous and the prognosis is worse off than just having a cirrhosis. Okay. So when you look at the slide I gave you a slide for cirrhosis, and then I put a man there, and we went through in class. This man here is showing all the various features of chronic liver disease, okay? Possibly cirrhosis and HCC. You can see that the man here from head to toe, the failure of the liver can lead to a catastrophic damage to all your system. Why? Because the liver is very, very essential. And we go back to our basic sciences. You realize that the liver's function is very essential. detoxification. When we were young, we always, when they ask what's the function of the liver, you say detoxification. Yeah, that is what it actually does. It helps get rid of toxic substances. So if your liver fails, then these toxic substances would move into circulation, get high up into the blood-brain barrier, and then cross the blood-brain barrier, get into your brain, and then you have issues. You can have hepatic encephalopathy, eventually can lead to coma. Okay, we know that the liver is also essential for making proteins. So once your liver fails, then you know that your proteins that the liver is making is going to fall, and that also comes with issues. And if you remember a child with kwashiorkor who lacks protein, what happens? Usually they tend to have what? A big abdomen because of what? The ascites, right? And then the edema. This same case, the reduced protein production or albumin production by the liver is going to put the patient at risk of developing an ascites. That is one. The other cause of the ascites here too is the fact that you remember when we're doing cardiovascular, we said once you have an edema, two things: either you have a reduced oncotic pressure, which means that you have low proteins, right? Or you have an increased hydrostatic pressure, which means you have increased pressure in the vessels. In this case, once the liver shrinks, it tends to apply pressure onto the portal vessels, which move through the portal vessels are in the liver. They walk through the liver. So it applies pressure to these portal vessels, pushes it and increases the hydrostatic pressure in the portal vessels. And once you have increased hydrostatic pressure there, you are going to have fluid leakage into the interstitium, and hence you are going to have edema. So the edema that you have in chronic liver disease is because of increased hydrostatic pressure, secondary to the liver that has become cirrhosed, putting pressure on the portal vessels, and also a decreased oncotic pressure, which is secondary to low albumin production by the liver. The liver is also supposed to be making clotting factors. So once the liver fails, then it means that there are no they tend to have a jaundice because the liver is supposed to be getting with glucuronide and all that, and once it fails, then you are going to have an issue. So the bilirubin will precipitate in the bloodstream, deposits under your skin, deposits under the sclera, then it becomes yellow, you have jaundice, right? So one of the main features that you see in chronic liver disease is the jaundice, the ascites, the bipedal edema, okay, which we've talked about, all that. Because of the increased pressure in the portal system, which we said is because the scarred liver is squeezing so much on the portal vessel. Because of that increased pressure, you are going to develop what we call collateral. Okay, what happens is when pressure develops in some place, the blood has to find somewhere else to go because pressure is building up. Okay, that's how the body is made. So you start making new blood vessels under or at the point where the esophagus joins the stomach. You start making new blood vessels there, right? So we call that esophageal varices. And these new blood vessels, they have a very, very weak wall. They are not like your usual arteries with strong wall and all that. So once the pressure grows stronger, the force is transmitted there, blood will bypass and gets into this esophageal varices that we've talked about. And with time, because esophageal varices are not strong enough, they can rupture. And when they rupture, your patient is going to come to you with severe hematemesis or vomiting with blood in it. And that is one of the main ways that they tend to develop anemia, and we end up losing them because they come vomiting lots of blood, right? And already this patient has bleeding tendencies and all. So once you have a ruptured esophageal virus, your clotting factors aren't helping you in any way. You are also vomiting, and then you are losing lots of blood, right? Sometimes it can rupture, and then when you pass to, because the blood is coming from high up, you pass stool and you realize your stool is dark, what we call melena stools, okay? Also, this same pressure that causes the formation of the collaterals can cause you to have distended veins on your abdomen. So if you watch the head of Medusa and you look at this man's stomach, you can see something like Medusa's head on the stomach. And this is basically because you have dilated abdominal veins. And this is arising because of increased pressure, because once pressure goes up, we need to transmit the blood elsewhere. So the veins on the abdomen, which ideally they aren't visible, this time becomes visible because you now have a lot of blood going through it. So it becomes dilated, and then we have what we call caput medusae, okay, or head of Medusa over there. So this picture here tells us or shows us the features of chronic liver disease. It can also have what we call spider nevi, which looks like blood vessels, superficial blood vessels in the form of spider over there. And then usually when they talk, their breath smells like a freshly opened corpse. Okay, we call that feta hepaticus. So these are the features that you see. So you try and go through. We've already talked about that in class and the investigation. Our main focus will be on the complications, and the complications. I've been talking a lot about increased pressure in the portal system. Okay, so portal hypertension is one of the main complications. If you look at slide 9 of your cirrhosis presentation or PowerPoint, you see that increased pressure in the portal vein will lead to formation of collaterals. And this formation of collaterals will give rise to esophageal varices and rectal varices, which I've talked about. And this may rupture with hemorrhage. So if you have a case study of a patient who has been described of having signs of chronic liver disease, comes to you vomiting, then you know that possibly there's a ruptured esophageal virus. Okay, I've also talked about the ascites, which I said 1 could be due to increased hydrostatic pressure, 2 could be due to reduced oncotic pressure. Okay, and then the liver disease itself will cause you to retain water and salt because your renin-angiotensin system is activated. So that will also worsen your edema, and your edema can get worse because bacteria and all that, they like moist environment. So you are going to have a superimposed bacterial infection. And this is what we call a spontaneous bacterial peritonitis. Okay. Then you can also have the encephalopathy, which we've talked about, that the blood would now bypass the liver. And even if it's going through the liver is unable to filter the waste substances. So it gets into the collaterals, passes higher up into the brain, and then you have encephalopathy developing. Okay. With all this edema and all that, so it's telling you that fluid is being pushed from your vascular compartment to your extravascular compartment. And hence there's going to be reduced blood supply towards the kidneys. And this is going to lead to hypotension and then possibly a kidney failure. This we call hepatorenal syndrome. So hepatorenal syndrome is kidney failure secondary to liver failure, just because there's poor supply to the kidney. Okay, you're also going to develop a hepatopulmonary syndrome, which is also failure of your lungs, secondary to a liver failure. So what is happening is that your lung is supposed to make sure you're getting oxygen into your system. However, you're going to have reduced oxygen because of dilatation of your pulmonary vasculature. And dilatation of your pulmonary vasculature, you remember we said will lead to what? Edema, pulmonary edema, and all that. So once you have pulmonary edema, you're going to be breathless. Okay, so this is called hepatopulmonary syndrome. Okay, then also pressure can build up in your pulmonary vessels. Okay, that can also lead to edema. We call that portopulmonary hypertension. And then lastly, you can have what we call hepatocellular carcinoma developing because of your liver disease. The link will drop now. So let me just drop it. We reconnect again. We take questions and then we move on to the next. I know we are tired, but bear with me. I'm hoping that this session might be the last. It means we need to run. So let me drop it and then we'll take questions. Okay.
All right, that's fine.